Hi, and welcome to another video from the CTAD Clinic. We have two special guests with us today. So you know me, I'm Mike Lloyd, I'm the director of the clinic, and with me are two people I've known for quite some time. It's Shannon and Diane. So I'm going to let them introduce themselves to you in a short while. And the topic of the video today is going to be all about eating disorders and dissociation. And there's going to be lots of mention of dissociative identity disorder, also known as DID. So that's really where we're at on this topic. It's something that I've seen an awful lot in clinical practice, but I'm not really trained in working with eating disorders. So I've just had to sort of muddle along and make it up as best as I can do with all the help that I can get. And these two folks here are really, really good at the eating disorder side. So it's an absolute pleasure to have you both here today to help us all understand more about the sort of links between these two sort of fascinating fields that cause people so much difficulty. So yeah, it'd be really nice to start. Just kind of introduce yourselves and let everybody know kind of who you are and where you're at in the world, really.
Yeah, thanks, Mike. It's really good to be here. I'm Shannon Wittevrongel, and I am a therapist in Seattle, Washington, and I've been practicing for over 10 years now. And my two areas of specialty have kind of evolved into eating disorders and trauma and dissociation. So this has been I love the way the work kind of interweaves and love supporting people as they recover from both.
Yeah, thank you, Shannon.
hmm
And I'm Diane Summers. I'm a dietitian also in the Seattle area, although I much prefer the term nutrition therapist. And I've been working in eating disorders for 21 years now. And the past handful of years have moved into working a lot with the intersection of eating disorders and DID. So it's such a pleasure to be here and to have this conversation today.
Yeah, I'm really looking forward to it. I think I'm going to learn a lot from it. So I'm kind of like the fact that other people are watching this is nice, but I'm kind of here for me so that I can soak up as much of your insight and experience as possible. You're both fabulously experienced. And not many, obviously there's quite a lot of people in the world of eating disorders, and there have been for many, many years. Not so much in the field of dissociation. So I guess, why go from eating disorders into dissociation? What sort of carried you into our little world, really?
Yeah, for me, it was a client. I was working in the eating disorder field and had a client that in our work together realized the client was a system and it totally transformed the way we were working with the eating disorder itself.
Right.
They were able to move into much more freedom with food. But they're also the reason, I feel like that client is the reason I ended up in this field.
Yeah, which is a very
And working
familiar
with,
story. It
yes,
tends to be like that.
yeah, yep, yeah. The client that actually introduced me to you, Mike,
Oh,
introduced me to
okay.
your channel as we were like both learning about DID together. They're like, you need to follow this guy. So here I am.
So you and I have probably known each other almost as long as you've known that client, I suppose, Shannon.
In a way, yeah,
Yeah.
yep, absolutely.
Oh, yeah. That does sound
hmm
extremely familiar. Yeah. How about yourself, Diane?
Yeah.
What was your route into this?
Well, various levels of trauma are so common
Mm,
in eating disorders. And so my sense is that I've honestly sat with multiple people, likely over the past 21 years, who have DID, but it's more been over the past handful of years that I've had both capacity to identify it
okay.
and
Yeah.
realize
Mm,
that I'm sitting with folks who are operating out of a system,
okay.
and and then working very closely with Shannon and a number of my own clients who have identified that they have DID. So it's been definitely the eating disorder field that brought me into trauma, that brought me into DID.
Yeah.
hmm
That which makes an awful lot of sense. I mean, I suppose working with eating disorders, does trauma tend to be a sort of an ever-present factor within that world just generally?
Yes.
Yeah, absolutely.
Okay.
Yeah, and we'll talk a little bit more about this later, but just the fact that having an eating disorder in and of itself can be experienced as a trauma,
Mm.
and then also the trauma of living in diet culture, of
Right,
culture that is constantly telling us we need to be fighting our bodies and changing our bodies. That's actually a very traumatic environment to live in.
yeah. And I suppose it's a kind of intergenerational thing. I mean, my understanding with eating disorders, the folks that I've seen have got maybe not the eating disorder bit, but certainly eating difficulties. They come from families where that's sort of been a pattern within the families. Is that something that you've seen as well?
Yeah, it can be. Yeah. I mean, just like trauma can be intergenerational. We
Yeah.
often see that kind of trickle down. It can shift depending on kind of how it's manifesting in each person, but absolutely. Yeah, and growing up in a family where the relationship with food is complicated or
Mm.
shame ridden is very much traumatic too.
Okay. So if I was kind of thinking like a Venn diagram, you've sort of got like the trauma, the eating disorders, the dissociation, and then the DID. What's it been like for you to sort of like walk, kind of go through that pattern and look at that intersection or the transition of all of those things? How have you found working with such complex conditions such as DID?
Honestly, I think for me, it sort of just makes sense.
Ah,
I
yeah.
think I mean, part of my getting to the field of eating disorder, I went into school with the intention of studying trauma,
Mhm.
like studying to treat trauma. Met Diane and learned about eating disorders and started to see the overlap of
Right.
the way trauma removes your, like, impacts your ability to trust your body, to feel safe in your body, to feel at home in your body. And then I was hearing that's eating disorders too, the
Yeah.
like interruption of this innate ability to trust your body and know your body. Um, so I think it just sort of made sense that that would be, yeah, like it's kind of like I feel like I'm always doing this with my clients, like a little bit of trauma, a
Right.
little bit eating disorder, a little bit of trauma, a little bit eating disorder. And then I think the dissociation, just because that is honestly, I think dissociation is core for both trauma and eating disorders. There's a dissociative component in both. See, I don't know if it feels like it's that complex. It just feels like here we are.
There
Yep,
it is.
this is
It's all just,
this is yeah, this is here.
yeah.
This is here. This is all part of it.
And is
Mhm.
with you, Diane, in terms of thinking about the dissociation, because clearly you've worked with eating disorders for many, many years, come into dissociation later on. How's it been for you to start recognizing the dissociation and start seeing it? What's that been like for you?
Yeah, I think it has added so much to the richness of my conversations with clients that both eating disorders and DID are brilliant and resilient ways of navigating the horror of trauma.
Yeah.
Mhm.
They're so brilliant. Uh, and
Yeah.
so to actually be able to step into uh, the beauty and the complexity and the nuance of a system and how each alter may have their own form of an eating disorder based on the trauma that they hold.
Right.
It
Wow.
I almost don't have words, and I think that really speaks to like how in awe I am of this form of coping. I hate even that it's called a disorder. It's
Yeah.
so pathologizing when I'm thinking this is amazing. This is
I know.
and like the gift it is to step into the brilliance of a system and how that can be actually utilized to support healing and recovery.
Yeah.
So it's been a joy. It's been an honor. I'm so grateful. I can't believe I get to do this work. And when I sit with clients that have that intersection of eating disorders and DID, I feel alive as a clinician.
Yeah.
It's such a joy.
There is
Mhm.
something really unique, I think, about the world of DID in terms of how we approach it. I totally get what you're saying about the disorder side of things because it seems odd to call something that has such a protective quality
Yes.
a disorder. And I suppose eating disorder, you've got the same thing built in. I mean, it's going to be
Mhm.
there to try and protect people from something. I suppose my take on the traumatic bit of the disorder is that it kind of worked fine when it was really needed, and then the disorder bit is it's got out of hand.
Mhm.
It's sort of how we look at it. Is it the same within the eating disorders? Does it sort of start as if it's like a logical place and it makes sense, and then it just kind of takes off, and then the person gets lost within it? Is it like that at all?
I do think it's a slippery slope.
Yeah.
And I also think no one consciously comes into the decision of I'm going to, I would say very rarely would anyone come into a decision of I'm going to have an eating disorder. So I think the etiology and the beginnings of it is not necessarily at a conscious level. And oftentimes it's not seen as an issue or something that's gotten really out of hand until someone is pretty deep in it.
Sure.
Yeah. So yeah, there's probably some similarities, you know.
Yeah, I mean, I know sometimes people don't, I suppose the nature of something like anorexia, that people don't necessarily know that they have it, and they don't see it in the way that people see it on the outside. And it feels like there is a similarity there with a lot of dissociations, that people are heavily dissociative but may not really be aware of it. And trying to get the message across and trying to help people understand what everything means and what we as clinicians are seeing is really tough. So how do you sort of approach the sort of the eating side of things? Like, what's your sort of like the framework or the model or the approach that you sort of take, that you really kind of hang all your work upon?
Yeah. So when we think about an eating disorder, it is a disconnection from the body's inherent wisdom. That gives
Beautiful
us,
way of putting it.
thank you.
Yeah.
That gives us such valuable information about our appetite, our hunger, our fullness, what our body is needing or wanting, how much and when. And there's an abandonment of that wisdom, on the behalf of finding something that feels like an effective form of coping. And like Shannon said, I've never heard a story that doesn't make sense.
Right.
At the end of every story, I think makes so much sense.
Makes sense.
Why we're here and how we got here. It always makes so much sense. And so, eating disorders in and of themselves are very dissociative, but also tend to have a hyper focus. So there's a dissociation from the body and a hyper focus on an external kind of structure or framework to eating that is not from their internal body wisdom.
Right.
So the work is really about reconnecting. And both Shannon and I work from a unapologetic health at every size framework, and we can share a little bit more about that.
Yeah, no. Do you say health at every size? Is that what you're saying?
Every size.
Every size. Okay. Wow.
Yes.
Yeah, please. I'd love to know more.
Yeah. Okay. Yeah, you can Google the Association for Size Diversity and Health.
Okay.
And that is the organization that houses the Health at Every Size trademark and lectures. It's phenomenal.
Wow. Okay.
And basically, Health at Every Size is the complete antithesis to what diet culture represents.
Right.
So I talked a little bit about what diet culture is and how it does cause people to leave their bodies in the name of pursuing some sort of change control over their body. And we could literally do 5 hours on health and exercise.
That might be something that would be good to come back to specifically, because I think the kind of the external social pressures and the burdens and demands, expectations and things like that, I think, there's a lot there which is, built into the sort of like just the trauma of existence, I suppose. So that might be something to come back to. Yeah.
Absolutely. Yeah. Yeah. So yeah, the work that I do on the food level is bringing, as clients are able, because we don't want to overwhelm nervous systems or have someone feel very thrown overboard by a level of challenge that's beyond what they can hold without bringing harm or
Yeah.
more dissociation to themselves. So it's always paced in a way that is intentional and protective. But the hope,
Yeah.
if there's capacity, is to reintegrate at some level with the body's wisdom,
Right.
and the body's knowledge around what it wants and how much on a food level.
So this feels very, I mean, the body centric in that sense that we're not just thinking about the way that person views, perceives, and understands the world. There's something fundamentally built into the relationship to the body, which obviously a lot of people with traumatic dissociation struggle with. The sense of sort of self-hate or self-criticism about people's bodies that I've encountered is phenomenal. And I guess you're seeing exactly that within the eating disorders world. That you must be, right?
Yeah.
So how do you because this isn't something I've heard of, but again, I'm not in the eating disorder world, so I don't know if there's something that has filtered through to the UK, that the health at every size. Is it international or is it kind of specific American thing?
It is
It's huge,
international.
but it is international.
Mhm.
Okay.
Yeah.
I've just missed this
Mhm.
completely. Okay.
Well, I'm so thrilled that we get to put this on the radar. But yes, and actually one of the phenomenal, I mean, health at every size has a long history
Mhm.
of coming about. But yeah, actually one of the movers and shakers within the field is actually in the UK.
Fantastic. Okay.
Oh, yeah. Yeah.
That's great. And Shannon, thinking about because you had your first client with
Mhm.
DID, and obviously you started with that eating disorder. So you've been working with this program, you've been understanding and have knowledge of this program. So how did the work with DID sort of like join that?
Yeah,
Were they disconnected? I mean, I'm guessing they weren't, but I'm
not
going
at
to ask
all.
anyway. Were they kind of
Yeah.
disconnected, two separate strands that you had to work to put together, or how did the
The
process go?
eating disorder and DID are health at every size and DID.
Right.
Just to clarify your question, both.
How does that work then? That sounds
Ah,
fantastic.
okay. Okay. um, yeah, that with trauma, like we know, it sets up this dynamic with your body where your body feels like it betrayed you and you can't trust it. So it
Okay.
creates that cutoff, right?
Mhm.
Um, and if we were treating eating disorders from this prescriptive, like this is what everybody should eat and this is what everybody should look like,
Yeah.
we kind of repeat that same dynamic that separates somebody from their body and it doesn't become their own. So much of the work with eating disorders from a health at every size perspective and trauma feels so like wonderfully integrated, and that the goal for both is to reconnect that person to their own body and to their own sense of safety within their body. And I think we do a real disservice to people when we're treating an eating disorder from a more prescriptive place and not from the sense of an very individualized, client centered, body trust centered place,
Yeah.
because it just repeats the same patterns of harm that create the dissociation, that create the disconnection, and then continue to kind of play out in lots of different ways. Yeah, so there's
Yeah.
so much overlap.
And that must be of comfort to people when they sort of bring the eating disorders first and foremost, because I guess that's why they would find therapists and nutrition specialists working within the program and things. And then the DID is there. If it's there, it's going to sort of start emerging and fronting. So have people sort of spoken about the ease by which they're able to share their dissociation with yourselves? Because it's such a
Mm-hmm.
hidden thing. People may have spent years and years and years hiding it, and I guess the eating side of things is harder because it's visual. It's about the body. It's about the food behavior. How have people sort of like found the comfort with the program? Have you got any kind of examples where people have arrived and been able to just, it's almost like with relief, sort of share their dissociation with practitioners in the program?
Yeah, I think rapport is so important in relationships. So in the beginning, I may not know, and because we're still building trust and rapport, but I do find that over time, I get to start to hear about essentially different eating disorders that exist within one human being.
Yeah.
And how they're held in different times in their lives. And so it might not be something that someone starts out with, especially if they themselves are not aware yet.
Mm-hmm.
But over time, in in a safe context, I do tend to find that we eventually get there. Yeah.
Mm-hmm.
Yeah. Rapport, get the trust, which are all very sort of familiar constructs within the sort of this field of dissociation. You mentioned earlier, Diane, about different parts having different sort of maybe eating disorders or food preferences or food traumas as such. So I'm going to sort of expand things out a little bit from just DID into the OSDD, the other specified side of things, because I've spent quite a lot of time working with folks with OSDD that are pulled either towards or away from food or eating behaviors, even if they're not, like, say, losing themselves in a DID way. The power of the influence to move and behave and change behaviors can be huge. What can you help us, both of you really, sort of help us understand about the way that the internal systems of dissociation can be so heavily involved with food and eating? Like, why is that such a thing?
Because food's essential to life.
Yeah.
That's the first thing that comes to mind.
Yeah.
It's so core to our experience of being human. And it's also so core to our experience of being social beings. And so in the midst of trauma, I think food can be used in ways to connect or disconnect from other people. And that creates some really tricky dynamics.
Think about those dynamics, thinking about the internal system, so that you have different parts, so either coming forward and altering behavior or they're influencing behavior. What kind of things can happen with food in general and eating behavior with the systems being powerful and taking charge? Like, what problems do you see, or what difficulties do people experience with food having internal systems like this?
Yeah, I think part of what is probably, if I were to guess, I could be wrong, Shannon, but what's happening for probably both of us is it's like the number of ways that can play out is so grand. And so it's kind of like, how do we actually funnel this into words?
Where do you start?
And that is because, like Shannon said, we interact with food multiple times a day. It's just a necessary entity, like hydrating our bodies, like having shelter. I mean, it's at the basic human need. And so it's therefore it's a vulnerable entity actually in anybody's life. It's so vulnerable because it's something we have to experience and engage and approach multiple times a day to actually be a living human being. There's no avoiding it. So I'll just give one example, but in incredibly abusive homes, oftentimes the basic human needs are threatened. Shelter, warmth, hydration, food. And so these pieces can be weaponized against children. Food can be withheld, can be controlled, all the way to diet culture, bringing families to go onto diets all together. And the first one that someone goes on is at age 5 before they even know what they're doing. And so it's just because we engage with food multiple times a day, it is such a vulnerable realm in everybody's life.
Do you think would it be fair to say then, Diane, that pretty much everybody who's got DID or OSD, that kind of complex traumatic dissociation is likely to have some sort of issues with food and eating. I mean, is that almost guaranteed or?
That's my working theory. Yeah.
Yeah.
I haven't met somebody with dissociation or trauma that doesn't have something complex with food.
Yeah. I mean, I find that as well. But obviously,
Mm,
I'm maybe approaching from a different angle, really. But food just
mm,
does seem to be such a central component. There's
yeah,
always something there. And
yeah.
how do you navigate? I mean, where do you get started thinking about let's say a DID or OSDD system where there could be half a dozen or a dozen different parts, identities, others within, and then there's just one mouth, one pair of hands, one stomach kind of
Mm.
thing, you know. Where do you even start trying to unravel the logic and the sense of it? It feels like it's just enormous.
The way we would with any client, we start with what's in front of us.
Okay.
So start with whoever, whatever part, whatever version, whatever state the client is in, and learning. Tell me about your relationship with food.
So would you do that with almost every part? Would you kind of go through and just kind of work it out like that?
Yeah, sometimes. Sometimes it's not that systematic. Sometimes I learned from one part about another part, what's happening for another part, and then
Okay.
eventually that part might come and join the session and we can talk about it.
Yeah.
I think a dynamic that can happen frequently is parts that have really very, very radically different presentations of their eating disorder.
Yeah.
So often the one that I will see first is a very restrictive part. The part that is
Mm.
probably looks kind of classically anorexic, um, very rigid in their way of eating. Sometimes it's about image. I think I've often seen like, well, I want to be small. I want like more of that diet culture kind of
Yeah.
language, which I think might be a way of normalizing like this. Everyone else is doing this. This is just part of the world. But often, kind of right underneath that is if I eat, I feel. And if I feel, I can't handle what is right underneath that. So it's
Yeah.
I mean, when you're starving yourself, your body literally has to shut down to a degree. And so you actually aren't feeling much. Um,
Mm.
Again, it's a brilliant way of coping with feelings that are much too intense. The
Absolutely. I can
thing that's
see
interesting,
the lure
yeah,
in that. Yeah.
absolutely. And why recovery can be so terrifying
Yeah.
for people with any level of dissociation, but really anyone with any amount of trauma. Like the recovery from a restrictive presentation of an eating disorder is very, very scary
Yeah.
because you get a flood of feelings that you've been very effectively disconnecting from. The thing that's interesting is that often in that system, including OSDD, there is a part or a self state that is determined to keep that body alive. And so we'll sometimes show up and it's like,
Okay.
we haven't eaten in 3 days.
Get
We
on
are
with it.
going to eat because
Okay.
if we don't, we're going to die. Um,
So the conflict
so
within must be
absolutely.
enormous then for that.
Yeah. But,
Yeah.
but that part, I mean, that part is like, save my whole system by like making sure that we eat. But then, yeah, there can be this battle between parts that have really different motivations and really different goals,
Yeah.
all with the intent of protecting the whole system,
Yeah.
all trying their best,
Gosh, yeah.
and kind of that balance.
Because
So a lot
there's
of
no
it is
one
like
part's like,
listening.
oh, but they're not doing it wrong, are they? I mean, there's like
No.
one's trying to restrict to avoid the feelings because the feelings could
Yep.
overwhelm and that could be at risk. And then there's another
Mm-hmm.
part saying, well, we've got to eat because that's the fundamental
Yes.
human need, and if we don't, then we're in trouble. And that makes
Mm-hmm.
sense. And yeah, the conflict is enormous, isn't it? I think.
And I think something about I think for Diane and I, the why we are I mean we were so committed to health at every size before even beginning to work with DID systems
Yeah.
and dissociation, but I think it feels even more salient because the health at every size perspective doesn't make any assumptions about what an eating disorder looks like based on a person's body.
Got it.
So I think what happens for our clients, particularly for parts that have like really varied presentations, is they feel really validated. We're not questioning. Oh
Right.
yeah, you binge. Yep. Oh yeah, you restrict a lot. Yeah. And we're not shocked because we're not making assumptions based on what their body looks
Yeah.
like. Eating disorders show up in every single body type. Restrictive eating disorders show up in every single body type. So I think what part of that sense of safety that you were describing, I think where I've seen that the most is in parts that are like, you're not going to believe this, but this is what I'm doing. We're like, okay, yeah, that makes
And you
sense.
do believe it.
And we do, yeah, because we have seen it everywhere.
Can I ask then, within, say, traditional eating disorder services, and I've worked with some and liaised with the ones locally here in the UK, and they're really not dissociation informed. I mean, I've gone in and I've done some training, and I think there's a lot more to do. How much is being missed then in very traditional eating disorder services, which tends to be about kind of hitting that magic BMI, and then that's your arrangement, just replacing the binge eating with something healthier, getting the BMI to a level where the person's weight is technically medically safe, but they're not looking at dissociation. So I mean, how much is being missed, do you think?
Ooh.
Ooh, that's an
I just need to take a
whole
moment
other
to
topic.
Take a
regulate
moment, yeah.
because
feelings about this.
actually, even without dissociation or DID being in the picture,
Yeah.
If the focus in eating disorder recovery is, a certain BMI or a certain way of eating. And first of all, I just want to name that's been the conventional belief and training for decades. And so it's always understandable when that's how clinicians kind of come at it because that's what they know.
Yeah.
And also as we learn more, we have to do better.
Yeah.
We have to do better on behalf of our clients, right?
Yes.
And so that's why the Association for Size Diversity and Health and Health at Every Size has been doing so much work around educating that health doesn't look like a certain BMI, that we don't actually, BMI is first of all, was developed by a statistician.
Okay.
At
Playing with numbers just to see.
literally playing with numbers, primarily with white young men.
Okay.
And so it's rooted for sure in racism and white supremacy and the medical industrial complex. It's weaponized against patients all the time to deny surgeries and medical care.
Yeah,
And
like
so
you don't hit this
and
number, you
eating.
don't access healthcare. It's that level, isn't
yes,
it? Yeah.
Yeah.
I've seen
it is
and
that level.
being denied eating disorder treatment too. Many. Yeah.
Oh wow. So how sadly ironic is that then?
Yes.
Okay.
Yeah,
Yes.
it's awful.
So maybe we could do a whole nother interview, another point about like what's wrong, everything that's wrong with the BMI notion, context,
Oh yeah.
strategy, approch. So
Please.
so let's agree within this that we think it should
come
be
back.
Yeah. Let's just move away from the whole notion of the BMI and think, because it's person centric. That's what we want to do. Look at everybody as an individual. Look at everyone with their own individual factors, their backgrounds, their understandings, and where they want to get to. And it very much sounds like our approach with dissociation absolutely matches the health at every size approach. Those two things are just in parallel. They are the same thing, which I think would be, of huge sort of relief and reassurance to people if they find a practitioner that's working within this approach and they have dissociation, because I guess the folks watching this are largely going to be dissociative. There's the knowledge that there are people out there that are going to know things.
Yeah.
We also know that they have to educate a lot of clinicians about their own condition. So what would be a good starting point for someone, let's say, who goes into an eating disorder service to try and help people understand the trauma and help people understand the dissociation when the focus is going to be on food and safety and risk and all that kind of thing? Where could they start?
No, I almost want to back up a little bit, Mike, to what you
Okay, yeah,
asked
no, please do.
initially about like what gets missed in eating disorder treatment when trauma and dissociation isn't taken into account.
Yeah,
I mean, I think the
agree.
BMI and help at every size, that's like a huge systemic thing, but on a more specific to those who go into particularly like a higher level of care, so where you go in for several hours a day or overnight, often the focus is you have to eat, making you eat,
Right.
getting through this
Okay.
meal plan without taking into account the impact on your nervous system and or
Yeah.
taking into account the dynamics around food that could be getting repeated in the treatment center itself.
Yeah.
It's tricky, and the balance is tricky
Mhm.
because yes, sometimes medically somebody really needs to nourish in order to stay medically safe. And if we're not being sensitive and aware of the person's nervous system response to
Yeah.
sitting down to a meal, and we're not supporting their nervous system to move closer to safety in the midst of it, there's just a continuing to override that trauma, like
Mhm.
override the sense of what their body needs. So even if they're like,
Yep.
this doesn't feel safe, I can't do this, you have to do it anyways.
I know.
Rather
Yeah.
than, you don't feel safe, what do we do?
What do we
Let's
do?
get you a weighted blanket. Let's get a dog at your feet. Let's get, there's so many different
Yeah.
ways that we can approach this that allow people's nervous system to settle a little bit
Yep.
so it's not re-traumatizing. Often treatment can be very re-traumatizing to people who are
I'm hearing that. Yeah.
mhm,
I think Diane, you mentioned the phrase the weaponization of food, and that's something that I've
mhm,
used in clinical work quite a bit. And Shannon, what you're describing there is the potential that a service that is, well-meaning, that they're trying to
mhm,
find the health and well-being of the person in front of them, but the re-traumatization, the re-experiencing of weaponization of food is like eat or else kind of thing. You must eat. These potentially are the same narratives
mhm,
that a lot of people will have heard in childhood around the meal table or the absence of the meal table, whatever it might be.
mhm,
So if services aren't aware of this stuff, they are potentially making it worse in the attempt to make it better.
mhm,
Absolutely. And
mhm,
oftentimes too, kind of like what Shannon was saying, there's a very prescriptive way of eating. And sometimes if eating disorder programs themselves have not done their own work around diet culture, they may actually be continuing to promote this certain way that somebody has to eat,
Sure.
which continues that dichotomous belief of there are good foods and there are bad foods
mhm,
versus all foods are available, all foods fit.
Yeah.
Um, let's actually make peace with all foods.
mhm,
Okay.
That all foods that that person actually wants to be able to feel well and peace and freedom around. And so that's another piece that can get unfortunately just missed
Yeah.
if the eating disorder program themselves are still very entrenched in diet culture,
Yeah.
and diet
mhm,
culture being dissociative and disconnected from the body.
Okay. So I'm going to sort of shelve the earlier question and sort of move sort of stay with that, because I think what advice can you offer, or what would you like to steer clinicians working in eating disorder services towards in order to try and really help them get the trauma and the dissociation link to really see that? What can they do to be different?
I think one of the biggest things is to one day, as it feels safe and ready to be able to hear the stories of
mhm,
food throughout someone's lifespan. Oftentimes, I mean, how we come to the table, how we feed ourselves as adults is deeply rooted in childhood stories
Yeah.
that have involved food and oftentimes trauma being paired with how that food experience played out. So I think coming to every client session just with a spirit of curiosity and interest in what those stories throughout the lifespan have been. And also just holding one of the biggest things I've learned in working with systems is that this is very long-term work.
Yes. Yeah.
There is nothing quick about it. And if it was quick, it wouldn't be kind.
mhm.
Wow. Yeah, I resonate with
Mhm.
that heavily. And,
Mhm.
having talking to me over the time we've known each other, that, I'm an advocate for long-term therapies and the quick fix. You can quick fix a problem, but you're not changing the nature of anything. It feels sometimes like it's just papering over the cracks in the wall. I think what you're talking about is really going back to the start and having a deep understanding of the life. And that can be tricky with dissociation because that's often taking people back to a place that they struggle with. So I agree with you. I think trying to get the nature of the stories of food from people all the way through their lifespan means that we have to find a way of making it safe for people to go back into their past and
Mhm.
remember and being able to share those stories. So we have to do both, don't we? We have to look after the dissociation that might stop them from doing that in order to get to the stories about the food, which is massively impacting on their life. That's so kind of entwined in the sense that we have to take time for this.
Yes, absolutely.
Yes.
And like, what you're naming in terms of being able to care for the dissociation enough to be able to go into those stories. This is why I just don't ever treat somebody without that has dissociative tendencies without a therapist on the team. We're
Yeah,
always dietitian therapist team,
Okay.
because that's just safe and supportive. That's just a good, structure for that client to be held in.
yeah. And I
Mhm.
can see how I've missed out on this because I suppose I'd be in your position, Shannon, that sort of like the therapist
Mhm.
got some, knowledge of this, knowledge of that, and things. And then if we get into those stories of food, I'm not going to know the nature of the impact upon that on the body, the nutritional aspects of what they're talking about, and how the body is responding to a lack of or too much of or whatever it may be. So
Absolutely.
that's something that I think we can learn in terms of our services around dissociation is how do we link in with folks that are completely understanding of nutrition and diet and all of those kind of things. So not working on our own when it becomes apparent how important food is.
I think it allows the therapist to be able to go deeper too.
Yeah.
Um, I think when I know that a client is being well held around their medical care, around their
Yes.
nutrition care by another provider, um, I can be curious and get into more of the nuance of like, where did this come from?
Yeah.
Knowing that somebody else would make sure, are you eating enough? And
Yeah.
what is that looking like? Yeah, and I think your question about like, what do we hope other clinicians take from this? I think if you're a therapist and you notice your client seems to be struggling with food, don't hesitate to explore getting them a dietitian that's health at
Sure.
every size and trauma informed.
Yeah.
Um, and I think what we were also talking about earlier, like being really cautious about not making any assumptions about your client.
Sure.
Like, always ask, like, tell
Yeah.
me what your relationship with food is like. Tell me what your experience of hunger and fullness is. I
Yeah.
think we often don't understand the complexity of what it means to be hungry or the complexity of what it means to be full
For sure.
and the distress that both of those can cause.
And that's
Being
such
really
a
care.
such a powerful point, Shannon, that because the fear of working, sometimes we see this. So when people say to me, why don't more people get into work with DID? Why are there so few
Mm,
practitioners? And I say, because they kind of look at it and they go, it just seems so hard or odd or
mm,
strange or just like I'm just going to get sucked into that and I'll never find my way out. And then I talk to some people who have gone into the world clinically of dissociation and DID and OSDD, and I start talking about how do you feel about working with people with eating disorders, and it's like, oh God, no, that seems too hard, and that seems like I'm going to get dragged into that and never come out. So it feels like these are just kind of like reasons almost to not engage with the work because it's scary. And I think I'm really hoping that this
mm.
conversation is will alleviate some of that fear that it's don't
It's
do it on your own, right? I mean, that's the thing. It's like if
no.
you're going to work,
Mhm.
if you're a DID professional like myself, and you're going to work with someone who's got a significant eating disorder, don't do it on your own. Go get the help, bring the
Mhm.
people in, form a team around that person, and you know,
Yeah.
access the
And
specialism.
also don't be afraid to ask the questions of your client. don't be afraid to discover an eating disorder.
Yeah.
Don't shy away from asking the
Point.
questions that could bring to the surface really complex food stuff.
We have to ask those questions. We have to get those, we have to find that knowledge to do something, particularly well. Like, we have to have those questions answered, and not to be frightened to say, how bad is it? How significant is this? What impact is this having? And if it's big, we got to hold that and stay put with it and go get some help.
And I feel like Diane said, these are the most amazing humans to work with.
Yeah.
Clinicians are missing out if they're afraid to work with people with DID or eating disorder, because they are the most incredible human beings, and the work is so stunning.
Yeah. And this is odd, isn't it? And I think I was interviewed in a podcast recently, and I said the same thing. It's just, this is the most wonderful work. The people that you meet, the stories, it is just incredible. It surprises me that more people aren't interested in it, and just how enjoyable this work is. And I think people on the outside will look at what we're talking and go, oh God, that you've just doubled down on all the horrible stuff that I want to avoid. Dissociation, DID, and eating disorders? No way. And yet we're talking about it, and we're sharing that we've enjoyed this work, and it's magical and it's wonderful.
It really is.
But I think there's an inspirational component to conversations like this, because it really helps people understand that there are plenty of people out there taking this work on, enjoying it, doing this really difficult work and loving it, and not wanting to trade it for anything else. I don't think you're going to move into another specialty. This is the one, right? This is where you're sitting. This overlap between eating disorders and dissociation is where you found yourselves. And I absolutely take my hat off to you guys. I think you're doing absolutely wonderful work. Could you, I know I'm going to put some links in, so there's an opportunity at the end of the video to sort of drop some links to resources and places like that. But just while we're here, while we're talking, what would you say are the really obvious go-to places or books or other channels, maybe other educational sources, so that people can just jump into something and start getting to know more about this?
Well, there's not yet a ton of overlap between eating disorders and trauma in books. We're waiting for Diane to write her book someday.
Ooh, okay. Nice. I like the sound of that.
I hope that was okay to drop that, but
Totally.
okay, good. A podcast that we really like for kind of moving away from diet culture and like healing around eating disorders is Maintenance Phase. It's a really phenomenal podcast with a lot of great resources. Diane, will you jump in? The ASDA website will give you the link to the Association for Health and Size. Totally lost it. Hold on. The Association for Health and Size Diversity. Oh my gosh.
Size Diversity and Health Association.
Yeah, it's
Association
have a lot of words, right? There's lots of words and acronyms and things.
It's a lot of letters, and we'll have it in a link.
We'll have it in the link. Yeah. Places.
Yes, Association for Size Diversity and Health. Yes.
Yeah.
So the Association of Size Diversity and Health is really a wonderful resource as well.
Yeah, like Shannon said, there's not a ton on the intersection of dissociation, eating disorders, and trauma. The Center for Body Trust is really wonderful, and Hillary and Dana recently also launched a podcast. In terms of understanding more, I just briefly hinted at the connection between white supremacy and BMI. There's a wonderful book called Fearing the Black Body, The Racist Roots of Fat Phobia.
Okay, right.
A book called Anti-Diet by Christy Harrison, who's a dietitian. We can send you a lot.
I do. Please do. So we can load up the description at the end of the video with some really good links for people to go to and access, and for me as well, so I can start like looking at this stuff and getting more information, because I think it's going to be really useful for us here at the clinic as well, to really kind of build our knowledge and build our awareness of this. So we're going to start grabbing your expertise as much as we can. I think we'll need to. Oh, no, go on. Yeah.
Just real quick. Yeah. And I think for clients who are listening, people who are experiencing dissociation and eating disorders, I know both Diane and I would really want you to know that there is so much hope. It can feel so overwhelming when you're in the thick of it. And there is so much hope for relief and for connection and for freedom. There's a lot of hope.
I think that's a very important string for people to clutch and start holding on to. I'm really glad you jumped in with that, because so much of this work can feel hopeless, and even people in services, in specialist services for years, they can become hopeless within the services. And I think it's folks like yourselves that are really sort of shining that beacon big to say there is hope, there is opportunity for wellness here in whatever way that looks. That's not my wellness imposed on you, or my concept of wellness imposed upon you. I'm going to find and we're going to work out what your wellness needs to look like and then work towards it. And I think that does feel like that's got hope, because everybody then isn't being judged by a category or a design or a shape. And that's what we've never wanted in DID, that you're judged because, you've got to fit this or got to fit that, got to fit that. We've always been open to the infinite possibilities of it. And I suppose that's what you're saying with eating and food as well. It's infinite in terms of its possibilities. So let's charge ourselves up, and then let's look for all of the possibilities that there may be. Well, thank you, Diane. Thank you, Shannon. It's been an absolute pleasure to spend time with you, having this conversation and kind of relaying all our thoughts and your amazing expertise from many, many years of working with these people for whom they can often feel lost, that there aren't folks out there, and they're around. And I think I'd like to thank you on behalf of all the subscribers, the viewers, and my team, and people out there in the world that are really pushing the flags for the work that we do. It's been an absolute treasure speaking to both of you today. So I'll draw it to a close. So thanks everyone. I'm sure that both Diane and Shannon would be interested in sort of having a look at the comments, and there may be additional questions that you can put into the comment section. And it would be lovely to maybe come back and do another video between us where we can maybe just answer some of the questions that people have in this field, because it's a massive field. There's going to be lots of questions. So please do put some questions into the comment section. Do like and subscribe to get more content from the channel, and do feel free to share the video. And if you're working with people who you think you might be a clinician, you might share this with your colleagues, or you might be someone who has these conditions and you're living with them, please share them with your therapist, because there's always more for us to learn. So thank you very much for the video, for the time to go through all of this stuff today. And for me personally, I've just loved chatting with you. It's just a wonderful thing to be able to share time with folks that are equally as passionate as I am about this field. So thanks ever so much. So to all watching, please do, as always, take great care.